Started. Hi, everybody. Thank you so much for joining us today. I am Michelle Morris from Consolidated Planning Group. We love presenting these webinars to you with helpful information and educational information for families who have an individual in their life with any kind of disability, whether it be developmental or intellectual. We are here to help. And today we're going to be talking with Dr. Lindsay Asawa about how autism is evaluated. A little bit before we get started, kind of some housekeeping items. We do record all of our webinars. After the webinar is finished, we will email you a link to that recording. We will also email you the slides that we go over today. The recordings go to our YouTube channel. So I've put that information in the chat box. So you can go look at our YouTube channel at any time and watch any videos that you would like when it's convenient for you. The other thing I want to let you know is that we cannot see you or hear you because we're in webinar mode. But we know you're out there and we welcome your questions and comments. So please just put those into the chat box. And as we see questions come in, we are so happy to make sure that those get answered as much as possible. But if not, you're welcome to contact us afterwards and get those questions answered for you. Maybe we miss it, or maybe you're just not interested in sharing your question in front of a large group of people. That's fine too. So again, I am with Consolidated Planning Group. We are a financial planning firm. First of all, we've been in business for over 30 years. We have over 30 years of experience. And we do things like life insurance, investments, securities, all of that, but through the lens of understanding that your child might need your help for the rest of their life, not just for the rest of your life. And most financial advisors, they're going to plan to the end of your life and through your retirement. We take it a step further because not only do we do anything that any traditional financial advisor does, we also do special needs planning, and we can help you navigate those benefits and make sure you understand the nuances of the rules and regulations surrounding things like SSI and Medicaid, ABLE accounts, and Social Security retirement or survivor benefits, all of those kinds of things. We also help you consider the cost of your child's care in the future. So we are members of the Special Needs Planning Academy. We are chartered special needs consultants, and we are nationally certified as Social Security advisors. Now, we are located just outside of Houston in Missouri City and Sugar Land. But we work all across Texas and all across the United States. So if you know of anyone living in the United States, feel free to share our information with them, share these webinars with them. We are here to help. And again, families really come to us because not only are we going to be able to help you with your money, your financial future, your retirement, but thinking about protecting your family. If maybe the main breadwinner in your family passes away early, that could cause a major disruption. So how can we protect your family against negative situations like that? What about the lifetime care of your loved one and the fact that they're going to be here after you're gone? You can't simply pay for their needs anymore. More planning has to be done around that. Transition planning, there's a lot in terms of when your child turns 18, when they graduate from high school, when they move on to maybe a residential community, and when you pass away. There's a lot of different transitions that you need to plan for your loved one. We can help you understand ABLE accounts and special needs trusts and other vehicles that can help you save money for your loved one that will not affect their benefits. And of course, we are here to advocate for you and to educate you on all of these topics. You might be having a hard time finding answers to your questions. And that's because not very many people have taken the step to really understand the nuances of special needs planning. The reason we do this is because all four of the financial advisors here at Consolidated Planning Group, we're all parents. We all have or have worked with children with disabilities. And we truly have taken the time to learn everything that we can about it. Almost every single client we serve has a child or a loved one with some kind of need. And, out of the entire United States, there are over 263,000 financial advisors. But out of those 263,000, fewer than 200 focus on special needs planning. Not 200,000, just 200. That's less than a tenth of a percent of all the financial advisors in the United States who truly get your family. So we can help you develop a future care plan, and we suggest that no matter where you are, you start now. We will meet you where you are, whether you're a thousandaire or 100,000aire or a millionaire or a billionaire. It doesn't matter. Maybe you're a high net earner who is not rich yet, or maybe you're just searching for those benefits and how can I get help for my family? What resources are available? No matter where you are on the scale, we can help you. We meet you where you are. We want you to think about planning earlier versus later because then you have a longer runway to make small changes that will have a large impact on your family's future. Think about what's going to happen after high school. There are vocational options, there are residential options, and there are fantastic educational options. So, look into those things early and start planning and just be very, very careful. If you think that a sibling is going to be able or willing to step into the role of caregiver, being a caregiver, as you know, is very difficult and it puts a lot of strain on your life. Not many people want to give their child that strain just because they have a sibling with a disability. So be careful about that. I will let Dr. Asawa take over since I'm having a little coughing fit, and she's going to go through how autism is evaluated. Thank you so much, Lindsay, for being here with us. Go ahead and take over.
Okay, you're welcome. Thank you for the introduction. So, I am Lindsay Asawa. I'm a licensed clinical psychologist. I have a practice in Missouri City. I'll tell you a tiny bit about that in a second. But what I'm here to talk about today is autism evaluations, because that's something that our practice has been doing for many years. But I also want to talk about kind of what that process involves and when you might need an autism evaluation, what to be looking for. So there's several things that we'll go through, but let me see if it's going to let me change the slide. There we go. Okay.
I see
So
that.
it's
Perfect.
working. Yes. So this is just a little bit about our practice, Beautiful Brain Psychological Services in Missouri City. There's three of us who are licensed evaluators. We have two school psychologists, licensed specialists in school psychology, who also provide evaluations for Fort Bend ISD, and they also work with me in private practice. And so we do, between the three of us, we see all ages. We do autism evaluations as well as ADHD, learning disability, intellectual disability, giftedness, full psychoeducational evaluations. We help college students apply for accommodations on their college courses or standardized exams. And so we kind of cover the full range. And our our two school psychologists who work with me, they really actually kind of specialize in doing these autism evaluations in particular. They do these very regularly for all ages, but children as young as 2 years old. And so I'll talk to you more about how we do these.
Now, Lindsay, real quick,
Mhm.
looking at your pictures, it looks like are you just off of Knight Road?
Yeah, Knights Court and Highway 6. So right
Yeah,
next
so
to Olympia Gymnastics and
or over there by the
Elkins
high
High
school,
School.
by
Yep,
Elkins High School. Okay, perfect. Thank
that's
you.
right. So we're easy access to families who live in Siena, families who live in Sugar Land. We have lots of clients coming to us from Pearland, Richmond, from in Houston. So we kind of serve the entire area. And I do have on there my email address. Feel free to email me because I know this isn't going to cover everything. There's always going to be additional questions that come up, and I'm here to help. And so if you have questions, let me know. Um, and I can at least try to point you in the right direction if I don't know the answers. So, first, I want to talk about typical development because this is kind of what we start looking at when we're looking for an autism diagnosis. When I have a family come in for an evaluation, we have them fill out lots of background information, paperwork, so that we can learn a lot about your child. And we want to look at things like their early development, their motor skills, language skills, social emotional development, and we're looking at a lot of different things. And so I kind of listed a few of those things here. There's more that's not on this slide, but for motor skills, of course, we're looking at, at what age did your child sit, crawl, walk, but also their general fine motor skills and gross motor skills. So gross motor, we're talking about running, jumping, throwing a ball, riding a bike, those kinds of things. And then we also uh, ask about potty training. We want to know, how did that go? At what age did that happen? Were there any concerns with that? These are kind of things that we're considering because we want to see, is your child meeting those milestones as expected? And there's a lot of room in there. So we don't expect every child to meet these milestones at an exact age or an exact point. There is some wiggle room there that's typical. And so it's when there's milestones that are significantly delayed, or there's kind of some unusual things about that development. Those are times that then it starts to kind of pop up some red flags for us, and we may want to gather more information. So, language abilities. Um, Early on, we want to find out, were they babbling? Did they start mimicking sounds that they heard from others? Um, and how long did that go on? So we also have older kids who are continuing to mimic words and phrases. And is that something that you're seeing? We want to know, when did they use single words, but also when did they develop phrases and sentences, at what age? And then other forms of language, pointing to identify something that they want. Are they responding to their name, and at what age did that start? Receptive language is their understanding when they hear words, how well do they understand that language that they're hearing? And then expressive is, how well are they able to express and communicate using words? And so those are two different things that we look at. We have assessments that also look at both of those skills. And then another piece of all of this is not just, do they have language, but do they use it socially, and how do they use it socially? And that's a really big piece, because we can have some kids that have very advanced language skills, but they're not necessarily using those appropriately in a social context. And that is a key thing that we want to watch for. Um, so about social skill development, there's some things that we look at, also emotional development. We want to see, from a young age, are they smiling at others? Are they making eye contact? Um, how are their reciprocal back and forth interactions? And we look at this in our sessions as well. That's something I immediately start watching when a client walks in the room, is what are their reciprocal interactions with me? What does that look like? And is it age appropriate, developmentally appropriate? Did they show appropriate separation anxiety from their caregivers, or and stranger anxiety, at a time when that was appropriate and developmentally on target? Um, Joint attention is something that involves, both the child and another child or an adult looking at something and attending to it, paying attention to it together? So do they want to show you something and they want you to look at it and they will look at it with you? That's a joint attention. Or are they doing more kind of parallel play? They're doing their own thing. They're sitting next to you, but they're doing their own thing. We're kind of watching for those two things. Are they showing an interest in others, and at what age? And how are they showing that interest? And emotionally, can they self-soothe? And at what age are they starting to self-soothe? How are they self-soothing? Shared enjoyment, again, it's kind of looking at another person and smiling and laughing with them. And that's a social um, ability to be able to kind of want that shared enjoyment and want that other person to share in whatever it is that they're doing and what they're seeing and what they're smiling or laughing about. And then empathy is something that we pay attention to, and we want to know at what age and how are they starting to show empathy towards others. So these are just some of the things that we look at for as far as typical development. And when it's atypical in any of these areas, those might be some indicators that there could be a developmental or a neurological difference going on. And so autism is very complex, and as you can see, there's just a lot of pieces of the puzzle that we have to look at and we have to gather information about. Let's see. It's taking a second to go to the next
Yeah,
slide.
there is a little bit of a delay, but
There's
it
a little
does say
lag,
you're
huh?
controlling the screen. So try again.
Let's see.
There you
There it
go.
goes. Okay. So differences is kind of what we're watching for. And I use the word differences because that's different than using the word deficit. I'm not necessarily looking for deficits. I'm looking for differences because like I said, they may have wonderful language abilities, but they may use those language abilities a little bit differently than what is typical for a child their age. So these are some of the language differences that we kind of watch for and that are part of our assessments. So their early development, like I said, if they are delayed in maybe putting together phrases and sentences, if the way that they're speaking, we pay attention to the speed and the rhythm of their speech, the tone of their speech or the pitch. Some kids may use a very kind of flat and toneless way of speaking, very kind of mechanical. Some may use kind of an unusual pitch when they're saying certain phrases or or communicating with others. Volume is something else we watch for. Are they using kind of a socially appropriate volume when they're speaking, or are they just kind of loud all the time or unusually quiet? Echolalia is echoing back what they hear, either another person say or even echoing something that they heard on a video or a TV show. And that can be immediate. They may echo it back immediately after they heard it, or there might be a delay. They may days later, they may continue to echo that same phrase that they may have heard previously on a TV show or from another person. So that's something we watch for. Just repetitive speaking in phrases or words, but using them over and over again, and oftentimes out of context. Also, just kind of the unusual use of words and phrases. Like I said, they may have just excellent vocabulary, but maybe using those words a little bit unusually and different. Um, we do see pronoun errors at times, kids referring to themselves as you or she or he, as opposed to I or me. Um, and then those reciprocal, like I said, those back and forth conversation skills, we really pay close attention to those, especially at an age when when it's developmentally appropriate for them to really be improving those conversational skills. So these are some of the differences that our assessments are kind of looking at and looking for. Social interaction, some of the differences that we're watching for, like I mentioned earlier, eye contact. Now, that doesn't mean I'm watching just for no eye contact. A lot of the clients that I assess do make eye contact, but it might be limited. It might be kind of unusual making eye contact inappropriately, socially inappropriately. Um, Facial expressions, we watch for that. Are they typical? Are they developmentally appropriate? Are they directing those facial expressions at others and using the facial expressions to communicate something? We talked about shared enjoyment already, but that's something we watch for not responding to their own name, or to requests. And we test some of these things during our sessions. We try to see, are they responding to their name during the session, or are they responding to a request that we give them? If Are they initiating joint attention? Are they coming up to me and saying, "Hey, look at this"? And also, are they responding to it? If I say it to them, "Hey, look at this, look what I drew." And so, how are they using that joint attention? Social overtures, when we're interacting with others, is when we go up to them and we kind of invite them into a social interaction, or we start an interaction. And are they doing that? And how are they doing that? Are they just kind of grabbing your arm and pulling you over? Or are they looking at you, making eye contact, asking you a question? A lot of the clients that we work with, we're seeing a communication skills that are good, but that are also focused very much on what the child is preoccupied with. So something that is a preferred interest of theirs. I've had clients that want to spend the whole testing session talking about the same subject, and we keep going back to that and going back to that. So it's a really kind of some extreme preoccupations, or an object, maybe wanting to talk about something that's in the room and becoming fixated on that. The social give and take. So this is something that can get subtle, especially when we're looking at teens and adults on the autism spectrum. We're kind of looking at, not just do they socialize, but how well can they do that give and take? Are they doing all the talking in the conversation, or are they doing some listening and really processing what the other person's saying? And is that helping to guide the conversation? So that's something a little bit more subtle that we kind of take note of and ask others about. Stereotyped play and repetitive play, sometimes the kids and the teens that we work with, their play may be very kind of repeating the same themes over and over again, or repeating the same actions over and over again. Um, we look at how well can they do imaginative play, especially at younger ages. Social cues is something that's very important that we're always watching for and asking parents about. How well are they picking up on social cues? Now that should improve as they get older and as they mature. They should be kind of understanding that and picking up on that better. So when we have younger kids, kindergartners, we're not necessarily hearing as many concerns from teachers or from peers, because there's a lot of leeway. People overlook that. That's not something we really expect kindergartners to be good at. But by the time we have a middle schooler, they really should be picking up on some social cues. And if they're struggling with that, then that could be a concern. Also, just some of those social misunderstandings that can be kind of subtle, misinterpreting what people are saying to them. Misunderstanding something that might be a little bit less concrete. So a lot of our clients that we work with can be very concrete in the way they understand things. And if it's a little bit more subtle or abstract, they may have a little bit harder time and have some misunderstandings. And generally, just are they a bit socially awkward, or are their responses to others maybe sometimes kind of inappropriate, maybe saying the wrong thing in the wrong in a social situation, or accidentally offending others? So these are just some of those differences that we're kind of watching for, and it can look very different at different ages and different developmental stages. So we're really constantly asking, is this developmentally appropriate at this age for this person, based on their their cultural background, their upbringing? Is this a child that's been in a school environment or not? So we have to kind of consider the context, but also, is it developmentally appropriate? So behavior, this is another area that we're looking at, and their interests. And are there some differences in what is maybe typical for that developmental stage or that age? A lot of repetitive movements are some things that we see in our assessment. So rocking, toe walking, flicking fingers, hand flapping and spinning. These can be some of the repetitive movements we might see when kids are, oftentimes when they're excited. And I want to say, actually, I should pause really quick because I know as a parent, it's very easy to kind of see some of these things, and you might see one or two of these things and panic and say, oh my
Hmm.
gosh, what does this mean? My child
Well,
does this.
I was just thinking to myself, oh my goodness, my mom used to always tell me that I looked like I was wearing high heels because I was a toe walker.
Yes, okay.
Um, so any of these behaviors, by themselves or even,
Yes,
several of them might be, like you were saying,
yep,
appropriate for some children, but
absolutely.
you are there to watch for when a line is being crossed and a multitude of examples, right?
Right. And we're looking for patterns of differences in behaviors and in development. And we're putting it in context, like I said. So sometimes we can explain some of these behaviors. There might be some reason that a different reason why these behaviors are occurring. And we can't just look at any of these things in isolation. That's why I said autism is a very complex diagnosis. And it's something that you really do have to have a lot of experience and training knowing how to identify this. It's not something you can always see or identify on the surface, especially when at times when it gets to be a little more subtle. So yeah, absolutely. There's no reason to be concerned by single behaviors that you might notice in your child. But if you're noticing kind of groups of these types of behaviors, then I think it could be helpful to seek some additional assessment. It still does not mean that absolutely these things mean equal autism, right? So there could be many other explanations, but allowing a professional to gather all that information and put that together based on their experience and their training is really, really helpful. And not jumping to conclusions as a parent, I think, and I'm a parent of 3 children, and I completely understand how that goes. So I think it's a good idea to get the opinion of a professional who is objective and can kind of put all these puzzle pieces together. So a few of these other behaviors that we look at, posturing means just kind of um, forming hands and fingers or arms or body parts in a specific way and kind of holding it that way and doing that repeatedly. Some of the clients we work with have some self-injurious behavior, head banging, those types of behaviors. We also see some repetitive use of toys and play, like I talked about earlier, but also non-functional use of toys. So that would be an example would be like with this little boy in the picture, lining up cars, or flipping them over and just spinning the wheels on the car repeatedly, as opposed to, pretending like the car is driving and using imaginative play. So that's something we're kind of watching for in their play. A lot of insistence on routines, having to do it the same way every single time, insisting on that, getting upset if it doesn't go that way. Um, some of the clients I've had, it's to the point that they will children will insist that their parents drive the same route every day because the child has kind of memorized that driving route, and they'll get very upset if you turn the wrong direction at the stop sign. So that insistence on routines is another one. Ritualized behaviors, which sometimes can look a little bit like OCD, and I'll talk about that later, but we do have some kids that do some behaviors that look very ritualized or really very compulsive, um, and don't seem to have an explanation. And so a lot of the parents I've worked with have also jumped to that conclusion of I think my child has OCD. There could be some other reason for that. So again, it's a reason to get some further assessment. So hyperactivity and fidgeting. Now, this is something that can be very age appropriate, right? Especially in younger kids. Of course, they're going to be hyperactive at times. They're going to be fidgety at times. All kids have trouble sitting still. All kids are active. But we're looking at developmentally appropriate, for their age. Are they more hyperactive than what is typical? Do they fidget more than what is typical? And is it becoming a problem or not? Um, because in some cases it's not an issue and they're able to manage it in different settings. So that's something we look at. Again, this is something also that overlaps with a lot of other diagnoses, and sometimes just personality related. So it does not directly mean autism. Excessive crying or tantrums, also age appropriate for younger kiddos, but how long is that going on? Is that continuing as they get older, or are these tantrums much longer than what's developmentally appropriate? We have kids that will tantrum for hours, um, and and generally kids will move on well before that, so that's something that might start to be kind of a concern. A lot of our clients are very preoccupied with specific, like I was mentioning earlier, specific objects or unusual activities, things that are just kind of not typical for their age, just kind of unusual, or interests that, like I said, can be very obsessive, very perseverative, hyper focusing on those interests. Sensory processing is another thing that we look for, and that is part of the diagnosis of autism. So many of our kiddos really struggle with sensory processing, and that comes across as sometimes very um, sensory seeking behavior, where they'll seek out lots of sensory input, or sensory aversions, where they will stay away from certain or avoid certain sensory input. And this includes things like being touched with or touching certain fabrics or textures, clothing, sounds. Certain sounds may really bother them, or they may seek out certain sounds, tastes, smells, visual stimuli. So these are things that they may either avoid or they may really seek out. We also have kids that have some unusual sensory interest in things. They will sniff objects, touch them in unusual ways, lick them, bite them. They may stare for long periods of time at certain objects. So we have clients that, will stare at a light fixture or stare at a fan that's spinning. And so are they staring, for long periods of time? And is it kind of repeated? Food preferences is another big one. So a lot of kiddos have very extreme food preferences. They will only eat certain foods, very picky eaters. And again, a lot of our younger kids are picky eaters. They all like chicken nuggets and mac and cheese, right? But
Just yesterday, my husband saw a really funny meme about try and tell me I can't eat mac and cheese when I'm a grown up, and we sent it to our kids because that's
yeah, exactly. I know. And we all understand that as parents. But I mean, in this case, and again, I kind of, when I'm assessing this, I just gather more information because it may be completely developmentally appropriate. But, are they only eating like three or four types of food? Is it the same food at every meal? Are they getting extremely upset when they are offered other types of food? Are they gagging on certain textures? Just kind of what are the details surrounding those extreme food preferences? And is it changing? Are they broadening over time or not? Are they remaining very extreme? Um, some kids want certain sounds repeated over and over again, or they want to play certain songs over and over again. Again, could be very normal, appropriate, developmentally appropriate. But there's also times when it's kind of outside that range of what's typical. Um, some kids can be very averse to physical touch and affection, not liking hugs at all, not wanting to be touched by others. Some kids have the opposite sensory seeking, wanting to touch, wanting to hug, to the point of struggling with um, boundaries. And that is another thing that could be an indication of a sensory processing issue, and it could be an indication of autism if we have a lot of these other factors there as well. And then there is a definite tendency to become overstimulated in a lot of our kiddos on the autism spectrum. And so, and it's early on, that can just look like tantrums. That can look like going into a certain environment and just getting very irritable, easily upset, tantruming, but not knowing what triggered it. For parents, that can be a real struggle because we don't know what's going on. Why is this happening? And it could be just all that sensory input. They're getting overstimulated, too much noise, too many people, too much going on. So, what is autism? So, those are kind of some of the things that we're looking at, some of the differences in development across some of these different areas. But how do we define autism and how do we diagnose autism? So, The actual diagnosis comes from the Diagnostic and Statistical Manual of Mental Disorders, the DSM. We're on the fifth edition of that. And keep in mind that these diagnostic criteria for a lot of these diagnoses change over time. When they come out with the new manual, there might be a change in the DSM-6. And we keep that in mind as professionals, but I want you guys to know that as well. So there have been changes over time in the diagnostic criteria for autism, which has impacted the rates of diagnosis. It's broadened over time to include kind of more things. And one thing that did also change in this DSM-5 edition is that we previously had a diagnosis of Asperger's disorder or Asperger's syndrome. And now that has been wrapped into this umbrella term of autism spectrum disorder. So this umbrella term includes these two categories of social communication deficits and restricted interests or repetitive behaviors. And so these are two categories that we're assessing for when we do an evaluation. The social communication deficits, there's three subdomains under that. And we need to see some differences in each of those domains in order to meet the criteria for the diagnosis. So one is social emotional reciprocity. That's that back and forth interactions, social interactions. Nonverbal communication is the second. So that's when we're looking at things like eye contact, and then ability to form and maintain social relationships and make friends and keep those friendships. So we're looking at all three of those, and these categories can include so many different behaviors. They can be pretty broad, I would say. And so this is why it takes a professional who is trained and who is doing a thorough assessment, because uh, again, on the surface, it's kind of difficult to just check off all three of those. We really have to look carefully and we have to gather a lot of information. And one thing I'll say right now, and you guys may have heard this phrase before, but if you've met one person with autism, then you've met one person with autism, because it just varies so widely across the spectrum. There's all, and these diagnostic criteria can vary so widely in each client that we see, who still may meet the criteria, but they may look very different, behave very differently. This other category, restricted interests and repetitive behavior, I feel like this one can be even broader, because it just can include so many different things. Repetitive and stereotyped movements, as we talked about, but also language or play. Any of those things fall into that category. That insistence on routine and wanting things to be the same, ritualized behaviors, that falls in that category. The sensory sensitivity or sensory seeking. Uh-oh.
That was my fault. I'm sorry.
Oh,
I'm trying to
whoops.
type in the chat box. Someone was asking when the fifth edition was created, and I was trying to put an answer in the chat box for that.
Oh,
I'm seeing 2013. Is that correct, Lindsay?
that sounds right. I don't have
Okay.
the year memorized, but that does sound
Yes.
right.
And Marlene, yes, you will get a copy of the PowerPoint of the slides. I'm sorry to
Absolutely.
have interrupted you, Lindsay.
No
Go ahead.
problem. And the DSM, by the way, they're constantly doing research, preparing for updates in the next manual. So they've been doing it already for years, working on the DSM-6. And we don't know yet what changes will be in there. We have to follow those guidelines as psychologists. But I can tell you they base it on just a lot of research, on years and years of very good quality research. They also have a team of some of the top professionals in the mental health field that are part of that process. And so it's a pretty trustworthy diagnostic manual. We all have our frustrations with it at times and with these diagnoses at times, but this is what we use to make those diagnoses. So this is what we have to stay within. So I was mentioning the sensory experiences, sensory sensitivity or sensory processing difficulties falls in this category. And then also those interests that might be very intense or very kind of obsessive at times. All of that can fall in this category. And so in this category, we need to see two out of those four domains. We need to see some differences in two of those domains. And that's how we kind of put together the diagnosis. Now, there's a little bit more to it on the next slide. Let me see if it'll,
Yeah, it's gonna take 2 tries for you to get that going again. I'm
I
sorry.
may go too far. Hopefully, I won't. Hmm.
I'll just do it. There you go.
There, okay, I'll let you do it. Okay, so the specifiers, these are important. Right now, under the DSM-5 criteria, there are 3 levels for autism spectrum disorder, and level 1 is kind of considered mild, and that is requiring support, so some support. Level 2 is considered moderate, and that's requiring what they refer to as substantial support. Level 3 would be more severe, and that would be requiring very substantial support. And within our diagnostic manual, it does give us some pretty helpful just examples and guidelines of how we can place a child in one of those levels. And we have to put a lot of thought into it. And that's why we have to gather all this information. And I have to really look at all of that, weed through all the information, look back through my entire report that I've written that's 15 pages long, and then sit down and really think about which level I would place this child in. So we do put a lot of thought into that. And we also have to indicate whether there's language impairment or not, because we can see kids with or without. We also have to indicate whether there's intellectual impairment, which is why, and you'll see in a little bit, that we always include cognitive testing, intellectual testing in our evaluations, and that's an important piece. Um, and when we're doing this, when we're making this diagnosis, we have to consider the possibility of some comorbid diagnoses, which means, other diagnoses that might be present at the same time. Or we might need to work on teasing that out because, like I said, sometimes autism can look like OCD, or vice versa. ADHD and autism overlap very commonly. A lot of the kids who are on the autism spectrum also may qualify as having a language disorder for either their expressive or receptive language abilities. There might be an intellectual disability there or giftedness on the other end of that spectrum. Developmental coordination disorder, which is another reason we look at those fine motor and gross motor skills, and very high rates of comorbidity with depression and anxiety disorders, especially as kids get older, kind of into their teen and adult years. We do see some pretty high rates sometimes of depression and anxiety. So that's something we watch for. And learning disorders, dyslexia, dysgraphia, dyscalculia, these are also things that we need to include in our assessment and could be comorbid. So these assessments really need to be pretty thorough and detailed so we can get the full picture. Um, I might need to let you do it again. It's not changing. There it goes. Okay. So I put this up here because we've always okay, the diagnosis says autism spectrum disorder, and we've always thought of it as a spectrum, like you can see on the bottom of the screen here, going from severe to mild. And at that mild end, you may have heard the terms high functioning autism. You may have also heard the term Asperger's disorder or Asperger's syndrome. And in the previous diagnostic manual, that was a separate diagnosis for kids who were kind of on that mild end of the spectrum. And now we're kind of starting to look at it differently, maybe a little bit more like a wheel. And it really seems to be a more accurate way of looking at this because it is really difficult to just say that a child is, at this end of the spectrum or at this end of the spectrum, because there's so many differences within that. And they may be very advanced in one skill and they may be really struggling in another skill. And so when we look at it more as a wheel, then we can kind of look at all these different factors and say, where are they in all these different areas? And so some of those bullet points I wanted to mention, the reason we see so much variation with autism is we can have kids who are all the way from nonverbal to kids who develop language very early and have very advanced language skills and vocabulary. Cognitively, we can have kids who are very low on their IQ testing. They may qualify for an intellectual disability diagnosis, all the way up to kids who are very highly advanced cognitively, and gifted in many areas. Adaptive functioning is another thing that we look at, which is just their daily day-to-day functioning, and how well are they able to dress themselves and brush their teeth and take showers, and just kind of those normal daily functioning skills. And that can vary widely. We can have kids with very high cognitive abilities and very low adaptive functioning skills, and so that's something we also have to include in our assessment. Socially, we can have kids who are completely withdrawn socially, not interacting at all the way up to kids who are actually very, very social and have a hard time with those social boundaries. But what they're struggling with a little bit more is reading social cues. So there can be some more subtle social difficulties, but they're very social, and maybe they have friends, and maybe they enjoy going to the park and playing. And but we have to look a little bit closer at what those social interactions are like. And then sensory, we talked about that. They can be sensory seeking, they can be sensory avoidant, or they can be a little bit of both in different areas. So there's just a lot of variation. So it really is more like a wheel. Okay, let's see. Okay, I wanted to mention this term neurodiversity, which many of you may have heard, but it's an important term to talk about because this is kind of the way that the mental health field is really seeing a lot of these diagnoses at this point. We're less focused on them as a deficit and more as just a type of neurodiversity. So this, I thought this was a good quote, describing neurodiversity: the idea that people experience and interact with the world around them in many different ways. There's no one right way of thinking, learning, and behaving, and differences are not viewed as deficits. And so I think I can speak for a lot of psychologists out there who really kind of have this perspective now when we're looking at these diagnoses. And we really do see that there's a lot of amazing abilities there that are kind of getting overlooked when we focus so much on deficits. So I know a lot of parents can be hesitant to evaluate their child, partly because of this, because they know that their child is amazing. And a lot of parents can get very kind of defensive that they feel like their child is incredible and has these amazing abilities and there's nothing wrong with them. And so why do this evaluation and give them a label? And what I would say is I see evaluations very differently. And I know a lot of psychologists throughout the country feel the same way that I do, is that we don't evaluate just to give a child a label and to say that there's something wrong. What we're evaluating for is a lot of other things. We want to look at their strengths and their weaknesses, both. We want to see, what do they need some help with and support, but also what's going amazingly well, and what should we, and how can that help with planning for their future. We also really want to understand their brain wiring. That's kind of the purpose of a lot of this testing. We want to understand, how is their brain wired? How does their brain work? And with autism, with ADHD, with learning disorders, it really is just a difference in the way the brain is wired. And we're wanting to understand it better and help parents understand that better. We also want to look at, why are some of the behaviors occurring, because they can be misinterpreted, right? And this happens all the time with our kiddos on the autism spectrum, that their behaviors are misinterpreted. People might think they're doing something intentionally, when really they're reacting to sensory input, or they're reacting to a need that's not being met. And we want to help everyone to understand that better. What are their sensory needs? We need to identify that. There's some really helpful strategies and therapies to meet those sensory needs if they're not being met. We want to help with school placement. So evaluations can help you figure out, what would be a good fit for your child as far as school goes, and what are some options in your area. And that's kind of our job to know more about those options. Also, if they're going to be in a traditional school setting, which is not designed for kids who are neurodiverse, then what kinds of accommodations might be helpful to them so we can make it a better fit for them. And with that diagnosis, they can qualify for those accommodations. So that's also important. And then there's a lot of different helpful therapies out there, to work on some of those skills that might be lagging, or to help meet some of the needs that are not being met for them, and just to give support. And the community resources too, lots of great organizations that are out there that your evaluator can often connect you with. Once we know what's going on and how your child, how their brain works and what they need, then we can kind of connect you with the community resources that can support your family and just helping come up with a plan for the future. And I know that's been helpful for a lot of the clients we've worked with. The parents have given us that feedback at the end of the process that they just feel so much more confident once they have all this information in knowing what to do next. What will be helpful, and how can we help them to succeed? Because that's the ultimate goal for all of us. That's our goal as well.
Yeah, it's so
Um,
important to provide clarity around those things.
yes.
Couple of quick questions. Are you at a spot where you can take just two quick ones,
Sure.
three quick
Yeah.
ones?
Hmm.
First of all, I think you mentioned earlier that you start at age 2. Is that right? Is that when you
Now, our
recommend
practice
that?
does. In some cases, there are psychologists who will diagnose as young as 1.5. But I would say that's probably the youngest in most cases. 1.5 to 2 years old. Usually, even earlier than that, though, we might be seeing some concerns and some red flags. And I would absolutely say to talk with your pediatrician at that point. Let them know if you have some concerns about their development. Because there's so much wiggle room in early development, that's one of those reasons why oftentimes it's helpful to wait a little bit to later to evaluate, but not too long, because the earlier
Right.
we can identify, the better. There's some really helpful things you can do very early on, that can help with some of those skills and some of those needs. Anyway, sorry, I jumped in with an answer, but was there more to that
No, I
question?
love that. No, there's a couple of other things. When you're diagnosing all of this, is having an EGG or an MRI helpful? Do you look at those, or is that outside
That's a
of your
good
scope?
question. No, that's a very good question. So neurologists do, and neurologists can also assess for and diagnose autism, but they do look at it differently. Yeah, they kind of go inside the brain and we go
Mm.
outside. So as psychologists, we don't do MRIs. We're not trained to read them or interpret them, but we look at other factors that are kind of shown on the outside. As you can see throughout this presentation, those factors of social, emotional, language, motor skills. We're looking at their development and what that looks like. We're trained to kind of look for those patterns. And they are trained to read some of those tests that look at the brain. I think both can also be very helpful. And I think there's no one right way to get to that conclusion, but oftentimes psychologists and neurologists do come to the same conclusion, just using different routes, if that makes sense.
Yes. Thank you.
You're welcome. Okay, so autism evaluations. I've been kind of leading up to this, and I think you get the general idea of the things that we look at. But this is a list of what we actually include in those assessments and what is involved. So we always do a parent, if it's a child or a teen, we always do a parent interview. We have some questionnaires that are very widely used. They are questionnaires that are that have computer scoring systems that help us to then compare your child to what is typical across the board for their age, because these questionnaires have been normed on hundreds of thousands of children. And so that's not, again, we don't diagnose based on any one thing. So this is all, I show a picture of a puzzle piece here because we see this as a puzzle that we're piecing together. And there's a lot of pieces to that. And we do not look at any one piece alone. So the parent interview, looking at talking about history and talking about your concerns, those parent questionnaires and looking at the scoring for those. We also, if the child has been in any sort of classroom environment, we would love to get an interview of the teacher, just over the phone, a phone consultation, or in person. We also have some questionnaires we always want teachers to fill out if possible that are designed for teachers. And ideally, we love to get a classroom observation. Now, in public schools, that's not always allowed or feasible. In private schools and daycares, we can oftentimes do that, but it's not critical. It just gives us some extra information that's really helpful to be able to observe and see what's happening in the classroom. We always include cognitive testing, and that should always be included. So keep these in mind when you are seeking out an evaluator. You can find out what they include, and I really would recommend including that cognitive testing because there's just a lot you can learn from that about their abilities and their skills, but also where they are on those. Are they kind of in that range of cognitive impairment, like intellectual disability range? Are they in the gifted range? Are they gifted in certain abilities? And we really need to look at that because that's part of the big picture. Now, the
That's
ADA,
important
oh,
that can be important for benefits as well, because there are
yes,
certain benefits available to from state and federal government that require you to know an IQ score. So if the
right.
IQ is below a certain range, there are certain benefits that they can get that others can't.
Good, very good point. And I would say too, this comes up sometimes, any IQ tests that you see online are not that's not what we do. So psychologists are trained in some very specific um, cognitive tests that have been around for decades, that have been again normed on thousands and thousands of kids, and that require specialized training and experience to be able to administer. They also include a range of different activities as part of that test. So we're not just looking at one thing like their language skills, we're looking at a whole bunch of different things. Because we know that someone can be high in one area and a little bit lower in another area, and we want to understand the full picture. So I would definitely steer you away from anything other than those those psychologist trained cognitive tests. And then the ADOS 2 is, I mentioned this one specifically because this one is one that many of kind of the best evaluators for autism are now trained in this assessment. It's kind of become the gold standard assessment for autism because it's an observational assessment. So it's based on our observations during the session, and it's based on a set of very specific activities. And with younger kids, it's going to look more like kind of play, and it looks like some games, and they just think they're having fun and they're playing. But we are doing some very um, kind of research designed activities that are designed to pull out certain behaviors. And we're trying to actually see if they will exhibit some of those behaviors in front of us, because if you take them to the doctor's office in that 15-20 minute time period with the pediatrician, they're not going to necessarily observe any of the things that you're seeing at home. And we want to try to really see some of that. So we have this really great assessment that pulls some of that out. Um, it takes a lot of training and experience to administer an ADOS 2 also. So that's something to know. It's a great thing to include if possible. One that I forgot to put on this list, but we always include is an assessment of adaptive functioning, like I mentioned in the other slide. So that's their day-to-day functioning skills. And we do always include that. Executive functioning, that is um, how well are they managing their attention skills, their ability to plan and organize, and getting their homework done, those kinds of tasks, getting chores, following instructions. These are all skills, executive functioning skills, that are controlled by the frontal lobe of the brain. And those are also all things that overlap with an ADHD diagnosis, which is why oftentimes we do see these two diagnoses comorbid, and we always include an executive functioning assessment, because kids with on the autism spectrum very commonly do exhibit some of those executive functioning issues. Maybe not to the level of having an ADHD diagnosis as well, but they may still struggle with some of those, and we need to identify that. If needed, this assessment should include academic testing. If they are in school, if there's any concerns there, we need to see where they're at academically and if they have any needs for accommodations. And then we have to look at emotionally, how are they doing? Especially as they get older and we see that risk of depression and anxiety, we need to make sure to assess for that and find out what they need to support them emotionally. And we always try to include self-report questionnaires, even for kids, but especially for teens and adults. Then there's some self-report questionnaires that we want them to fill out to share information about what they notice about themselves. And that can be really interesting too, because we can see how much self-awareness do they have. Some have more than others. So, okay. So after we've done, I have this slide and I think one more. So we're almost finished,
Yeah, we're
but
running low
I
on
just saw
time.
that
So if
it's 1 o'clock.
people has to leave, if you gotta go, thank you for being here. We'll send you the slides and the recording later.
Yes, and feel free to email me, but you guys will have these slides, so I won't go through all of this. This is just a little bit about what happens next after the evaluation. It typically, just know that it takes a few weeks to put these reports together for all psychologists, because these are comprehensive, detailed, long reports with a lot of information. But I really highly recommend working with an evaluator who does a feedback session. Now, some don't. And I've had a lot of clients come to me with a previous report that they didn't understand. And I needed to then help them understand that report. And I really think it's important for your evaluator to sit down with you and talk about the results, go over it, explain it, answer your questions. That's the point at which they can give you some referrals and talk about community resources. You can hold on to that report and please save that report. I also have a hard time with some clients getting a hold of previous evaluation reports because it's just been lost over time. And as a parent now, I'm a stickler. I save all of these things for my kids because I know there might be a need for that at some point in the future. So hold on to those reports, um, and learn more about the diagnosis. There's a lot of great information out there. I wanted to mention there's a website called autism.org that's basically the Autism Research Institute. And so it has a lot of information based on good quality research that you can read more about the diagnosis. I've listed some of the types of therapies that are often helpful for kids on the autism spectrum, and that includes, and I have the abbreviations, but these stand for speech therapy, occupational therapy, physical therapy, depending on their needs. ABA is applied behavior analysis, which is a specific type of behavior therapy designed for kids with autism. It's not necessarily something that's needed for all kids, but it's something that might be helpful for some. And then groups can be wonderful, social skills groups, especially for kids with autism. And then I would also say, so the other part and the last slide is about school evaluations. So let me go ahead and put this one. So this one is just a little bit about school district evaluations. Now, what I do and what I've been describing today is a private evaluation, but you also have the option in public schools, and even if you're not in public school, but because you're part of the district, you have an option to seek out a school. It's called a full individual evaluation, an FIE, through the district. It's free. Anyone can refer the child, but they can't do the evaluation unless the parent consents. So that's important. And a really big thing I want to say about these evaluations is just that they have a different purpose than the evaluations that we do privately. So the school district evaluation is specifically trying to determine, does your child meet the criteria for special education services based on 13 categories that the TEA has designated. It's not a medical diagnosis. They cannot give a medical diagnosis, but they are trying to determine an educational need. Now, sometimes those two things conflict, because there are times when the school says, no, there is not an educational need, but we might say in our private evaluation, yes, your child has autism, and here's some treatment recommendations, or here's some parenting recommendations. So we have two different purposes of why we're doing these. And so oftentimes both might be needed. And we have lots of families come to us that they've already been evaluated through the district, but they now want a medical diagnosis, or they may not. The district may have said there's not an educational need, but the parents know that there's something more there. And so that's a time when a private evaluation still may be very helpful. Also, if you have a private evaluation done first and then you go to the district, They do include that. They don't just shove that aside and to do their own. They do use those to support eligibility for services through the school, but they still are going to want to do some additional testing of their own as well. Um, and those reevaluations are every 3 years. And so the school district always requires that they do updated evaluations every 3 years, and they are legally required to follow through on the plan that they create based on that eligibility. So they're going to come up with a plan with services, and they have to follow through on that. Now, the last point on here is also really important. If you have an evaluation done through the district and you don't agree with it, with those results, you do have a right to request what's called an independent educational evaluation, an IEE. Not many parents don't know this, actually. It's not something that's advertised, but if you request this, then you are allowed to then choose a private provider who meets the school's criteria, and they will then do a second evaluation to get a second opinion, and the school will pay for that. So that's actually really helpful to know. And we our school psychologists who work in my practice, they do these IEEs, but not for Fort Bend ISD because they work in Fort Bend ISD, so they can do them for all other districts. So that's something we can provide if needed, but there's a lot of other psychologists who do that as well. And so it's just good to know that's there as an option for
So,
you.
Lindsay, if
Mhm,
someone comes back for reevaluation, can
mhm.
they remove labels once they're, assigned one thing and then they come back, they get reevaluated and they've
So yes,
matured?
yes, and there's two kind of routes to that. So in a private practice setting like mine, when we do our evaluations, if there's a reevaluation at a later time and the child no longer meets the criteria for that diagnosis for whatever reason, then yes, that the diagnosis will be updated. Or if it changes, if it's was initially level 2 and now it's level 1, then that change would be made. So sometimes an additional diagnosis of depression or anxiety might be added at a later time. So I certainly think the reevaluations are very, very important and helpful. And I would recommend them probably every 1 to 2 years if possible. I mean, if not, 3 years is a good time frame, only because also if you are then going to apply for accommodations, when if your child ends up going beyond high school, they're going to require the testing to be within 3 years. So 3 years is a good time frame if you can't do it sooner.
Fantastic. I've kind of zipped through some of my remaining slides in the background, but if you want a free consultation with Consolidated Planning Group, we can certainly help you. Dr. Asawa is there to help you. Does your practice take Medicaid or any of those options, Lindsay?
No, and that's a very good question. So our practice is out of network with insurance. We do have flat rates for each type of evaluation, and we do offer discounts at times. And so you can always contact me and I can send you information. I would say if you are looking for someone who's within your insurance plan, I would say to contact the insurance, find out psychologists in your area that are in network and who provide this type of testing. Um, Most who are out of network, like us, also will provide a super bill at the end of the process that you can submit to your insurance. And we have a lot of clients that are reimbursed for either a portion or all of the testing, or it can go towards their deductible. And there are organizations also in the community that can help cover the cost. So that's another thing to potentially look into.
Thank you so much, Lindsay.
You're
And thank you
welcome.
everyone who's been here. I know we've gone over time. This will be available on our YouTube channel. We will email you the information and the slides. You'll have Dr. Asawa's information. You've got my contact info. And please feel free to reach out to us if there is anything we can help you with, because truly we are here to help. I hope you all have a fantastic week. It looks like Lindsay, someone in the chat box wants to connect with you, so I'll make sure you get their
Sure.
information. Okay. Thank you, everybody. Thank you so
Thank
much.
you.
Bye bye.
Bye bye.